Okay. So yeah, before we get into the weeds, we actually also had a really nice conversation kind of talking about different schools of thought on atherectomy. Yeah, we just touched based on, okay, atherectomy has this like negative connotation because of overuse. But what about people's experience with atherectomy? Like when I started my job, it's true, 10 years ago, my partners necessarily didn't want to do atherectomy, maybe due to time or their experience. Like why is there just such a heterogeneous physician group out there where people are using it and not using it? Where did that come from?
That's a great question. So, that's actually, you have to take a step back to really answer that. And that's not specific to atherectomy. That's a problem that we as a community have with peripheral artery disease in general. Unlike the aortic world or even the carotid world, that has very specific kind of national metrics about what's acceptable. And, for everybody sort of like protocolized to some extent. PAD is the
Sure.
Wild West. That's the one area where you can do what you want, I can do what I want. And there's really, let's pretend that at the end of the day, you have a great outcome, I have a negative outcome in terms of the fact that the patient goes on to get amputated. No one's coming for me. I don't even know I did something wrong. Like, it's just like, this is what I know and this is what I did. And so we are trying, as a community to kind of personalize care and sort of figure out, but that the PAD patient itself is such a heterogeneous mix, as to how they end up in negative positions that we need to do a better job on the science. I mean, back to what we're talking about today, a better job on the science, because we've sort of jumped that piece and moved right into action. So what's happening in our community in PAD is, companies come out with all this stuff and they're like, use it. Use it, it's good on plaque, but good on plaque doesn't translate to, in this particular patient, will actually save their leg. Now, the FDA is starting to force some of that and saying, we want to know about the wounds, we want to know about the amp rate, we want to know about amp-free survival. And so the reason that we have such heterogeneity in the way that we all treat is because ultimately what we are doing is just what our fathers and mothers are doing. Like, I trained at Stanford, this is what Dr. Lee did, this is what Dr. Chandra did, it worked for them, and now I, as a fresh grad at Mass General, I'm going to do what I'm comfortable with, which is what they showed me. And then once I kind of, if I've got the personality type to want to do more and innovate more, I might go to a company and say, let me try this out, let me try that out. But a lot of people are like, this is what I do. And then the evolution, but then the problem with that is then they train their residents to do what they did. And they go out to, University of Florida and keep doing that. And so then you end up doing something that's not necessarily evidence-based, but just what your boss did. And that is why we have such problems. But then, that in and of itself is not the real issue. The ultimate real issue is that now a patient comes to hospital X, and if it's the cardiologist that's treating them, they get one line of treatment. If IR is treating them, different line of treatment. If vascular surgery, different line of treatment. And it can range from amputation all the way through like 10 surgeries to keep their leg attached. And that's not okay. And that's what we need to stop as a community, I think.
That's, I have to say, I've never heard it explained like this. You're spot on. I mean, the range, it's. I've never, thought about, just coming back from how we're trained and how it's so just the devices were all out there. You use what you want, and people get comfortable with what they like, and then that just kind of gets passed down. And really, that's kind of what's brought us here today. Yeah, you're right. My patient can go to the hospital 2 miles away and they'll get amputated. And then in our hospital, it'll be a totally different, approach. And how do you, now that we're already at this state, are we like effed? Like, are we already like, is that our, how do we now kind of get that control and cohesiveness back? What are some things we can do?
I think the number one thing is we have to get involved a little bit with the government side of things. And what I mean by that is PAD and critical limb-threatening ischemia is a major cost to our healthcare system, and is going to increase with the number of patients who are elderly and with diabetes coming down the pike. And if we don't sort this out on a national level and have these metrics in place, and what the beauty of it is that we don't have to invent this. This has been done already. If you look at cancer, so you look at what happened in the 1970s, right? So in the 70s, Nixon, of all people, so Richard Nixon, he knew that kind of the thing that was kind of pissing off the American public in the healthcare world was cancer. So he goes to the NIH and dumps a bunch of money into it and says, figure out cancer, big quote, figure out cancer. And the scientists start to work on it. And now what they did back then now has created, these medications that today, like let's say me and, your sister both get a lump in our breast. We go to a doctor. It doesn't matter if I'm in the middle of Missouri or I'm at Mass General. The protocol is the same. We will get a biopsy. They will tell us what the markers are. And then bang, I can go on the National, Cancer website, and right there will be what my chemo is going to be because of what I have. And so we, as in PAD, ironic, as you know, PAD kills more people than the top 3 cancers combined. So we absolutely have the need to focus down on that. And that's where I think we need to really focus. We need to say, let's go back to the science and build up again instead of trying to solve things out here blindly. So it's not going to be, Sabine and Dua. It's going to have to involve the NIH, researchers, calcium. I have a colleague who works down in Texas, Dr. Trisha Roy, a good friend of mine. She's wonderful. She's a Methodist. She studies plaque. And she told me, just in her world, there are 10 different types of plaque and how devices work on them,
Yeah.
So, you know what? Laser atherectomy might be amazing for speckled plaque, might be garbage for full cancer. We don't know. But we need to sort that out before we can jump to saying laser works. Do you know what I mean? So that's what I think the solution is. And I think our generation, if people are ready to do that, we just need the investment to be able to. And that will change the game, I think.
That's very smart. I think I'll play a little devil's advocate on there. Is that part of the way we could innovate? I have a personal friend who, has this terrible GI cancer right now.
Sorry.
And they're doing the protocols that are all in the NCCN guidelines. And then there's all this new stuff out there that oncologists won't give to him because they're so ingrained in this dogma of, like, it has to be this way. So almost sometimes that also minimize or limits innovation or adopting innovation. So there's just two. I mean, like that, then, you have these guidelines and some new device comes out. How do you get that incorporated? I guess it takes time and data.
I love that point, actually, because, it's so interesting. And that's like a microcosm for all like great societies. Everyone's like innovating and doing great things and incorporating in real time to some extent. But then we get to a point where like the processes and bureaucracy become so extreme that it limits who can be helped in this. And then you get, disparities and other issues because, if you're at MGH, maybe you can be in the trial. But, that patient in Missouri I mentioned,
that's exactly
no chance,
the issue.
right? Exactly.
Yeah.
And, that ultimately, in my opinion, the way to manage that is basically having people who understand that world and actually intelligently in real time keep reassessing. You never want to be locked in dogma. You have to say that, science is a living, breathing thing that changes. And but you also have to be careful. Like, back in the day, I've talked about this example before. When you went to buy shoes at a shoe store, you would go and you would be able, like your kids could like stick their feet into an x-ray machine at a shoe store and just keep hitting the button repeatedly and blasting themselves with radiation because it was fun and they could see the bones of their feet because nobody knew that if you, blasted your, and so, x-rays came out as this amazing thing, 100 and whatever years ago, but then very quickly were adopted without like the real understanding of radiation. Then we paid a price for it. Now we're sort of like back on track again, where even a pregnant woman can get 3 CT scans, safely. So I think there is a balance. And the key is that we have to ensure that there are people that have the time to really understand science and be able to integrate. And that comes back to then our healthcare system in terms of like, you can't have every single doctor working their ass off 24/7, making money for the hospital and have no focus on real science. You can't have rules in terms of like promotion and stuff where they want like quantity over quality. There was a Nobel Prize winner guy who actually in his entire 10 years working only published 2 papers, but he won the Nobel Prize with those 2 papers. And so I think what you're talking about is a system approach where we can integrate, but we just need to ensure that people are given the time and the grace to be able to intelligently incorporate things. The laser is a good example, actually, where you think of the risk benefit. Like if I use this on a patient, if it doesn't hurt them, but it may help them, and I don't have the data, I will use it. But if you tell me, if you do atherectomy, you can cause all these horrible things, but we haven't studied it yet, then I will hold back. And I think that's a smart way. But if you tell me, it costs money, and if you use the laser, it's going to cost you more money and it may not help the patient, As a doctor, I don't care. I want to do what I think may be best for the patient in that particular time. And so I think each thing should be approached very comprehensively, and that's the way you actually integrate while not losing focus on innovation.
I think we need everyone to do this. It'll be we need everyone to do it. I mean, healthcare would become, just in the peripheral vascular space, would become so much more, organized, because, like you said, you're right. There's all these we have these metrics in carotids, in STEMI, and stroke, and things are very, it's not the wild west what we have right now.